We did a study a number of years ago where we looked retrospectively, of course, at a series of patients that we did laser incision and dilation, laser incision, dilation, and steroid injection, laser incision, dilation, and mitomycin C, and there was certainly a significant improvement in our outcome with all three modalities of laser incision, dilation, and mitomycin C. The laser is a natural tool to cut scar tissue. The laser of choice would have to be the CO2 laser because it does get absorbed completely into soft tissue, and therefore it causes the least amount of collateral tissue damage. Your exposure per line of sight limitations can oftentimes be a problem. In other words, you may see the stenosis straight on, but it may be hard to actually see the corners of that stenosis and the inferior aspects of that stenotic area. The fiber becomes a more natural way to apply, a more facile way of applying laser energy. And the safety feature of having the OmniGuide fiber close to contact and a gas flow to remove the smoke of vaporization is a great benefit. So the ideal thing is to make incisions through the scar tissue, but to save as many islands of mucosa that are healthy as possible to serve as the nidus for regrowth, reepithelialization of that tracheal wound. So the temptation should be avoided to actually recreate a circumferential incision. Laser incisions are really relaxing incisions for the dilatation. Dilatation is extremely important, but the laser and the dilatation makes the difference. The balloon is less traumatic, and we do not have to remove the laryngoscope to apply the balloon. So the airway is still maintained, except for that immediate time period when the balloon is used. Reapply pressure 2 or 3 times to allow the stenosis to dilate at the point of where those incisions were made. Most of us are using mitomycin C to try to decrease fibroblast regrowth and rescarring. Wash the residual mitomycin C away from the wound with a saline or a xylocaine wash.